Committee meeting is presented. Do I have a
So moved.
second? Moving myself, all in favor?
Aye.
Okay. Joe, I'm gonna do what I always do, which is to throw a curveball to you, and I think that I'm gonna make sure we want to recognize the nursing team here at Metro Health. Having been a nurse executive at other institutions and having gone through the magnet journey, I want to congratulate you not just on attainment of the magnet status in your renewal, but the renewal at a distinguished level. So I did a little bit of research before I came here today. You're the only facility in the state of Ohio that has that. And I think that, Dr. Maury and I have already talked, and I'm expecting to see the banner hanging next time I come, which might be as early as tomorrow morning. So I'm gonna drop the baton on her.
I better go.
I think you need to make sure you take that out for a celebratory ride, because that is a very great accomplishment. It says a lot about nursing. And for the nurses here, I started my nursing career many decades ago. So I worked on cardiac intensive care unit. So just wanted to say that at the beginning of the meeting. Sorry for the off script, Joe.
A great segue.
At this point, I'll turn it over to the
Thank you, Ron, for that.
You're welcome.
We always start this meeting with our true north, that every patient we touch will receive equitable, safe, high quality, patient-centered care to afford them the ultimate patient experience. And I think this year is going to be the year of everyday excellence, that we can sort of reestablish this true north. So we're going to start with a good story with Stacy and the great catch. If you want to come up, Stace.
Good morning, everyone. I am so happy to have with me representatives from our 7 East unit, which is a telemetry step-down unit. We have
I'm Alex Neza, I'm the nurse manager.
I'm Logan, I'm a registered nurse. I'm Jennifer Hodak, I'm the assistant nurse manager.
Magnet, right here. So
Yeah, there it is. That's right.
So I'm going to share with you a story. Logan and her colleague, Chris, were preparing to take a lab draw. There are things within our system that help the caregivers make sure that they get the right patient with the right label to ensure they have the correct specimen. Well, on this particular day, those weren't firing, which were the safeguards that were there to ensure that we do not have a mislabeled specimen. At that time, Logan and Chris went to their nursing leadership, escalated it up immediately, and with that, informatics came, troubleshooted, and fixed the problem. Mislabeled specimen is one of our top incidents here at Metro Health. There has been a lot of work within pathology, nursing, as well as patient safety to decrease that. So, Logan, tell me, what's your culture like on 7 East, and why did you feel so empowered to speak up?
I feel empowered to speak up because I have 2 of the most amazing managers ever. They always allow me to come to their office and talk about things, and it's very much appreciated because I don't feel uncomfortable talking to them about like any sort of patient scenarios or anything that happens on the floor at the time of my shift.
Alex and Jennifer, what kind of culture are you trying to create up on 7 East?
Well, inpatient healthcare is like so fast paced. If you don't like prioritize huddling in the morning and giving that structure, that opportunity for nurses to bring things forward, it's easy that by the time it reaches someone who can do something about it, that it's almost impossible to reconcile what actually happened. So we prioritize every single day, huddle at 7 a.m. And the first thing we start with is, what are the big things that have happened over the last 24 hours? So that way we can get people like Logan to speak up and talk about those events. And in this case, it was caught.
Michael, any questions? Well, thank you for your great presentation. And once again, make sure you spread the cheers about your magnet status. So, thank you.
Thank you.
Thanks for what you do.
All right, this time we're going to switch over to the quality assurance performance improvement update.
All right, so Unfortunately, you're gonna hear I should be seen and not heard, but today you're gonna be hearing a lot from me. So we wanted to give the board an update on a term that's becoming very synonymous with quality improvement throughout the country. And it's been there for quite some time, actually, called QAPI, or the Quality Assurance Performance Improvement. And what exactly is that? So wanted to start with a little bit of grounding for those of you who may not be familiar with how the regulatory oversight works. But there are many, many, many organizations that have regulatory oversight at Metro Health. 3 of them are listed here: the Joint Commission, which is our accrediting body, Centers for Medicaid and Medicare Services, CMS, and the Ohio Department of Health, which is our licensure body. And licensure has been new within the last couple of years in the state of Ohio. We have never needed any, the state did not have licensure, so there was no licenses issued. I want to focus on that middle one. So what are the things that the Centers for Medicare and Medicaid Services hold us accountable to? It's called the conditions of participation, or the COPs. And these COPs are very wide. And part of that is the QAPI, which we're going to show here in a minute. The Joint Commission on that left side of the screen there, they have Joint Commission standards, which actually call the conditions of participation as part of them. And QAPI is part of that. And just so that the board realizes that when the Joint Commission is here, they actually have the authority to evaluate the conditions of participation. That's why one of the things that they're looking at. So they're not only looking at their own standards and accreditation standards, they're also looking at we ensure we have the conditions of participation. In addition, from the licensure side, we have to follow Ohio Revised Code. And you'll see that in Ohio Revised Code, QAPI is also part of that. And like the Joint Commission, CMS allows the state or the Ohio Department of Health to also evaluate the conditions of participation. So anytime that the state comes in here on a complaint, they're also looking at the broader picture of are we maintaining our conditions of participation for CMS? If you don't maintain your conditions of participation from CMS, what does that mean? That means you're removed from the system. What does that ultimately mean? That we can't care for Medicare and Medicaid patients. Specifically, we're not going to get paid for that. So you can see how these standards sort of overlap and how CMS has their conditions of participation evaluated. So if we look at the condition of participation number 42, and that's section number 482.21, that's coming from CMS, and you look at the Ohio Revised or Ohio Administrative Code coming from the state, they are very, very similar in their wording. And I put some of the highlights of that when it comes to QAPI plans on the slide. So number one is hospital, in order to have a QAPI plan, they must develop, implement, and maintain an ongoing data-driven QAPI program that is hospital-wide and addresses all departments and services, is ongoing rather than episodic. It reflects the complexity of the organization, and it focuses on patient safety, which what we just heard in our great catch, quality of care, and reduction of medical errors. It includes QAPIs targeting high risk, high volume prone areas such as OBGYN in the emergency department. It demonstrates governing body oversight, the board, and it uses data and analytics to drive improvements and track effectiveness. So when it comes to a QAPI plan, the system has its QAPI plan, and you can find our QAPI plan on board underneath the resources tab, and there's its own folder. And inside there is a 30+ page document that explains how Metro Health as a system addresses these issues and how we can look to improve on these areas. So when the Joint Commission, when CMS, if they were to come, and ODH comes, they're looking to make sure that we have these standards in place. So what I want to focus on right now is the first one there is how are we doing this in a hospital-wide way that's addressing all departments and services? So to do that, we have two very important committees that you see at the bottom, which is called CQUIC and SQUIC. There are Clinical Quality Improvement Committee and our Essential Services Quality Improvement Committee. Because if you remember on that previous slide, a QAPI plan is all areas of departments. It's just not clinical areas of departments. So on the left, you'll see our Clinical Quality Improvement Committee. That's where the clinical QAPI plans from our departments live. That's where the quality improvement at the department level is being done. The Essential Services Quality Improvement Committee, that's where your facilities, your logistics, your dietary, all have their QAPI plans and all have their quality improvement ongoing. Last year was the first year that we implemented and educated on a standard process for doing this system-wide. There's many different ways of doing quality improvement. We implemented a A3 thinking. It's a lean tool that helps with problem solving. And in your appendix, you'll see some education for the board on lean thinking and A3 thinking, as well as several great examples from both of these committees on the quality improvement projects that were ongoing. As part of this, I audit our departments and areas to ensure that they're meeting these standards. And the CQUIC and SQUIC, because they are our main mechanism of meeting regulatory compliance, we have 23 different departments and areas that participate in that committee. And over 29 A3s were presented throughout the year last year. If we look at those as of January, 45% were still ongoing. They still had some finishing up to do. 31 of them were complete, and they were starting to already think about or starting on their next project. 24 were in what we call a 30, 60, 90 to ensure that the changes that they made were sustained. And you have to look at these QAPIs to ensure that they're meeting one of those three things: clinical outcomes, or trying to improve clinical outcomes, decrease adverse events, or improve operational efficiency. And many of the QAPI plans that we have do all or some of these issues. So 93% looked at outcomes, 31% looked at adverse events, and 62% looked at improving operational efficiency. I'm very pleased to say that this group, the SQUIC group, has done just incredible work. They jumped on this A3 thinking with full force. They took this and ran with it last year, and we had some incredible projects of quality improvement that came out of this group. And you can see that there are 13 areas. All 13 of them completed a QAPI plan. And they all had ongoing quality improvement. And you can see the numbers there. 15% were ongoing, 8% are complete, and 77 are in that 30, 60, 90 because this was new for the majority of them. These areas never really did quality improvement within their own area. For example, one of the examples that's in your appendix, you'll see a QAPI plan in A3 that came from facilities. And again, they're looking for operational efficiencies. And the project they actually worked on was decreasing nuisance alarms after the generators come on. And they were able to eliminate that through good quality improvement. So these aren't earth-shattering projects, but it made a big deal in their workflow for this operational improvement, this continuous and continuous improvement. 31 of them, you can see, looked at clinical outcomes, 54% looked at adverse events, and 100% obviously were really looking to improve their operational efficiencies. For example, again, dietary, their project was looking at the time it takes to get a tray from the kitchen up to the floor. How long does that take, and how can we decrease that time? They're all done by data. And how we've really become successful at this is that we have a 5-member clinical performance improvement team. And each one of those members is assigned a certain number of these groups to help coach them and to educate them on the A3 and walk them through their A3 process, which has been very helpful. In addition, we also give education during the CQUIC and SQUIC meetings on A3 and lean terminology to help, keep these projects moving forward. So with that, is there any questions or discussion regarding the QAPI plan as well as our CQUIC and SQUIC groups? We've honored the 5 slides. So except one group, I have to call out our legal team. We only have 45 slides for this whole meeting. The legal has 10.
There's 2 of us.
There you go.
There we go.
Sure.
Take long. We can go to
Four-
executive
Force multiplier, right?
session.
So.
Good, Michael.
Is it reasonable to assume that every employee here has been introduced to the principles of lean?
It is not. It is not. And that is definitely something that we're working towards this year.
Just gonna say, stay tuned.
Yeah, continuous performance improvement is high on our list. The way I saw how it was embraced in that essential services group was, that's my favorite meeting to go to. They are so engaged, and they're so happy with their improvements. That's what we need to bring to the rest of the organization. So in those steps, in all of these projects, it's engaging the front lines because they have the answers. And it was really true and held true in that space, but definitely, even when it comes to our CQUIC group, physicians do not learn quality improvement. It's not part of our curriculum. It's starting to become part of curriculums. But quality improvement is its own science. There's good ways of doing it. There's bad ways of doing it. And there's multiple ways of doing it. So we are going to be selecting the way that we want the everyday excellence to occur at Metro Health. Continuing that education to the front line so that people know. What we need is this QAPI to roll off of everybody's tongue. Because when the Joint Commission comes in, they ask, what's your QAPI plan? And areas need to know that. And that's one of the goals this year as well.
Yes, sir.
Conventionally, in my experiences on the shop and factory floor on lean, one of the biggest obstacles is fear of sharing and losing the expertise and control. I suspect that's different here, but has that been a noticeable obstacle?
No, I think deference to expertise and high reliability organizations is critical. And these groups that you can see, like our manager level, they really embraced what the people doing the job had to say. And a lot of their plans were based on this. So I haven't seen that, although it's certainly
I hope you don't.
it's certainly something that, others have experienced, but we have here.
So I don't usually tell physicians that they're wrong, but physicians, health professionals are taught QAPI as a core. I'll give you an example for nursing. So nursing does a thing called PDCA. So when they're looking at issues related to nursing care, they do plan to change an act or care an act. So that's a pseudo QAPI. They just don't call it QAPI. Every day a physician assesses a patient, modifies a plan of care based on information they receive from the patient, their family, from labs, from radiology, and then modify their plan of care. So I think it's embedded in the culture. It's just not, it's not assimilated as QAPI. So reality, to me, it's part of it is re-educating them, saying what you've done is this, and that is a pseudo QAPI, but now we're going to take the next permutation of it and make it continuous and make it institutional wide. So I just want to say every healthcare professional is taught how to reassess and modify plan of care, which is QAPI to improve outcomes for patients. It's just now this mindset. And I think for us, the reason why we're presenting this today, Michael, is because the board has a responsibility for almost every accrediting body, including Magnet. When we were there with Magnet surveyors, they want to know the board's oversight on the Magnet process. Magnet process itself could be considered a QAPI project.
So based on what you just said, and want to make sure I understand it, culturally, healthcare may be more predisposed to engaging in quality improvement?
I think so. The problem ends up being trying to get the culture to embrace it.
That's right. It's time. It's the time.
It's hard.
And it is hard work. In the A3 terminology, when you look at some of those examples, A3 is based on the size of the piece of paper. This is a Toyota production model. But the whole left side is your plan, use, check, act are on the right side of the A3. We spend the majority of our time on the plan because that's when you're trying to figure out what the actual problem is you're trying to solve. So as Ron said, PDCA is an A3. There's multiple PDCAs that go into it. So we tap into that language even on the A3 itself.
Where did you say under resources on board?
There should be a folder, called, I think it's called Quappy,
Yeah,
isn't
it
it?
says floppy plan.
Quappy plan.
Under resources?
Yes.
Yep.
Yeah, go up a little
On the
more.
set.
The file folder on the left side.
I don't know that we see it.
We'll do it. We'll do it at a break.
Yeah,
we'll do it
We'll do it at a
at a
break. So any other questions? So. Okay, with that, thank you for the update. Next, we're going to move into executive session to discuss hospital trade secrets as defined by the ROC 1333.61 to consider the appointment, employment, dismissal, discipline, promotion, demotion, or compensation of public employees or the investigation of charges or complaints against a public official, and to conference with the public body's attorney to discuss disputes involving the public body that are subject of pending or imminent court action as defined by ORC 121.22G. Do I have a motion to recess the executive session?
moved.
Yes, these matters. Okay, I'll second it. Now we'll do a roll call. Dr. Walker?
Yes.
Ron Jidzki, yes. And we will now move into executive session.
And we're back in public session.
All right, we're now back in public session with no further business to bring to the committee. This meeting is adjourned.
Misery dance.